Welcome to Pulmonary Blood Vessels, Ribs, and the Muscles of Breathing. We're going to basically talk about everything but the airways. So this is part 4, the last part of a 4-part series. So pulmonary blood vessels and the pulmonary vascular system deliver blood to and from the lungs for gas exchange. In addition to gas exchange, the pulmonary vascular system provides to structures distal to the terminal bronchi, so the alveolus, the alveolar ducts, everywhere that there's gas exchange. Similar to the systemic vascular system, the pulmonary vascular system is composed of arteries, arterioles, capillaries, which are the tiniest. Only a single cell can go through at one time, venules, and veins. So some effects of the autonomic nervous system, which affect both the blood vessels and they can affect also the airways. So we're going to talk about type 2 and type 1 effects, the sympathetic and the parasympathetic nervous system. So if you remember, sympathetic nervous system is responsible for your fight or flight response. Your heart speeds up, it increases in strength of contraction, you're ready to run. Bronchial smooth muscles relax so that you can take in more air. Bronchial glands quit making secretions, salivary glands quit making secretions, the stomach quits digesting things, so do the intestines, and the eyes widen. The pupils actually get bigger so you can see that bear coming. Now, on the other hand, the parasympathetic nervous system has what I call a SLUD reaction. It decreases the rate of the heart. It decreases the strength of contractions. It increases your salivation. It increases your bronchial glands. It increases your urinary tract. It increases your ability to defecate. So all of those are in the parasympathetic nervous system. The eyes constrict, the intestines increase, because now you're sitting on your couch with your feet kicked up, so you can digest food, you can eat food, and you don't have to run out and from a bear. You're kicking back and on your couch eating Doritos. So here's a front view and a middle view of the lungs. So you can see the apex of the lungs, the upper lobes, the horizontal fissure, the middle lobe, and the oblique fissure and the lower lobe on the right. And then on the left you can see the upper lobe, the cardiac arch where the heart lies, the oblique fissure, and the lower lobe. Top of the lung is the apex, the bottom of the lung is the base. So in the middle you can see all kinds of blood vessels are stuffed in there, the pulmonary veins, the pulmonary ligaments, a main stem bronchus, and pulmonary artery. The thorax houses and protects the organs of the cardiopulmonary system. There are 12 thoracic vertebrae down your back. You can see that in the posterior view. The sternum in the anterior front view forms the anterior border of the chest. The sternum is composed of the manubrium, the body of the sternum, the xiphoid process. There's a joint between the manubrium and the body of the sternum, and it's called the nubrial sternal joint, and it's referred to as the sternal angle or the angle of Lewis. Clinically, the angle of Lewis is an important landmark. It identifies the approximate level of the second pair of costal cartilages and the level of the intervertebral disc between T4 and T5. The approximate beginning and end of the aortic arch, and the bifurcation of the trachea into the left and right mainstem bronchi. So this is the angle of Louis is very important. The 12 pairs of ribs form the lateral boundaries of the thorax. The ribs attach directly to the vertebral column posteriorly or in the back, and indirectly by way of the costal cartilage and in front of to the sternum. The first 7 ribs are referred to as true ribs because they're attached directly to the sternum by way of their costal cartilage. Because the cartilage of the 8th, 9th, and 10th rib attaches to the cartilage of the ribs above, they are referred to as the floating ribs. The 11th and 12th rib that you can see down on the bottom that just kind of hang out below are actually called floating ribs. So we have true ribs, the first 7, false ribs, 8, 9, and 10, and 11 and 12 that are the floating ribs. So I have a question. Which ribs are identified as the floating ribs? That would be 11 and 12. So lung segments. There are 10 lung segments on each side. So you can see that on the right side they are in 3 different lobes, but on the left side they're in 2 lobes, the upper and the lower lobe. Postural drainage is commonly applied by the respiratory therapist to patients with excessive airway secretions. Postural drainage involves positioning the patient with pillows or other bed positions and help to use gravity to help mobilize excessive bronchial secretions from the bronchial lung segments. This is very common with cystic fibrosis patients. As you can see, the picture indicates this is postural drainage, the postural drainage position for the anterior basal segment of the right lower lobe. The patient is positioned in a supine position, laying on the back with the foot of the bed elevated 18 inches. I want to talk a little more about the mediastinum and what's in the mediastinum. In the mediastinum, there's the heart, its vessels, all the great vessels, the esophagus, the trachea, the phrenic nerve and cardiac nerves, the thoracic duct, the thymus, and the lymph nodes of the central chest. The mediastinum is a cavity that contains all of these organs and tissues in the center of the thoracic cage, between the right and the left lungs. The major blood vessels, known as the great vessels, enter and exit the heart. Various nerves and portions of the esophagus, thymus gland, and lymph nodes also are here. If the mediastinum is compressed or distorted, it can compromise the heart and the cardiopulmonary system. Let's look a little bit at a right-sided pleural effusion. So there are 2 moist slick surfaces membranes called the visceral and parietal pleura. These are closely associated with the lungs. The visceral pleura is firmly attached to the outside surface of each lung and extends into the interlobal fissures. The parietal pleura lies on the inside of the thoracic walls, the thoracic surface of the diaphragm, and the lateral portion of the mediastinum. So it's on the outside, so visceral is on the inside, parietal is on the outside. The visceral and parietal pleura are held together by a very thin film of serous fluid, two flat moistened pieces of glass. The fluid allows the membranes to glide over each other during inspiration and expiration. So during inspiration, the pleural membranes hold the lung tissue to the inner surface of the thorax and diaphragm, causing the lungs to expand. Because the lungs have a natural tendency to collapse and the chest wall has a natural tendency to expand, a negative or subatmospheric pressure normally exists between the parietal and visceral pleura. In this picture, you can see what happens though when something that's not supposed to be there enters the pleural space. So this is an anterior-posterior view and lateral view of a chest x-ray showing a right-sided pleural effusion. So in that, there's actually too much fluid. It's an empyema, so it's an accumulation of fluid in the pleural space. How do we get rid of this? Well, we can put a needle in that and drain it. So another thing that's not supposed to be in the chest is air, and it creates something called a pneumothorax. This is the introduction of gas into the pleural cavity through an opening in the chest wall or a rupture of the lung. Gas accumulation in the pleural cavity causes the visceral and parietal pleura to separate and for the lung to collapse. This is because the lung's visceral and parietal pleura are separated. The lung's natural inward recoil force is no longer offset by the chest wall's natural outward recoil force. This allows the lung to collapse, as you see in the picture on the right side. Common causes of pneumothorax include a penetrating chest wound, like a knife or a bullet or a fractured rib, or rupture of the lung, commonly caused by too much pressure from mechanical ventilation. A pneumothorax can be classified as either closed or open based on the way in which gas enters the pleural space. In a closed pneumothorax, the gas in the pleural space is not in direct contact with the atmosphere. In an open pneumothorax, the gas in the pleural space is in direct contact with the atmosphere and can move freely in and out, like in a penetrating chest wound. The thorax. The thorax houses and protects all of the organs of the cardiopulmonary system. This is another picture of it on page 61. Each intercostal space houses arteries, nerves, and veins located right below each of those ribs. So if you're going to put a needle in someone's chest, you need to feel for the rib, find the top of the rib, and slide over the top of the rib in order to puncture the rib without hurting any of the veins, arteries, or nerves. Never go below, always go above during thoracentesis or chest tube placement. So here's the picture of a puncture site, and you can see that they're sliding the needle over the top of the rib, protecting the very important intercostal artery, vein, and nerves that lie below the ribs. In this case, they're going low because they're going to want to get fluid. If you want to get air, you go high in the rib. So let's talk about the main muscle of inspiration, the diaphragm. The contraction of the diaphragm and the external intercostal muscles activate quiet inspiration. The diaphragm is the main muscle of ventilation, and it's a dome-shaped muscular fibrous partition located between the thoracic cavity and the abdominal cavity, so it keeps your guts from sliding into your chest. Although the diaphragm is generally referred to as one muscle, it's actually two separate muscles known as right and left hemidiaphragms. So how do you breathe? Well, if you look at the movement of the rib cage during breathing, you can see that the accessory muscles of inspiration lift the ribs laterally, just like a bucket handle. And the anterior posterior thorax expands similar to a pump handle. You can see that the bucket handle on the side motion, and in the back the pump handle motion of the muscles of inspiration. The external muscles, external intercostal muscles, come from the lower border of each rib and basically the upper limit of the intercostal space, and insert into the upper border of the rib below. In front, the fibers run down and medially, and in back, the fibers run downward and laterally. That creates these two motions. So, external intercostal muscles between the ribs. The scalenus muscle are three separate muscles that function as a unit and are known as anterior, medial, and posterior scalene muscles. The primary function of these muscles is to flex the neck. When used as accessory muscles for inspiration, they elevate the first and second ribs, decreases pleural pressure, allowing inspiration. The sternal cleidomastoid muscles are located on each side of the neck. They originate from the sternum and the clavicle, and they insert into the mastoid process and the occipital bone of the skull. Normally, these muscles pull from the sternoclavicle origin and rotate the head to the opposite side and turn it upward. However, when the sternocleidomastoid muscles function as an accessory muscle of inspiration, the head and neck are fixed by other muscles, and the sternocleidomastoid muscle pulls from its insertion on the skull and elevates the sternum. This increases the anterior posterior diameter of the chest. Next are the pectoralis major muscles. The pectoralis major muscles are very powerful fan-shaped muscles located on each side of the upper chest. They originate from the clavicle and the sternum and insert into the upper part of the humerus. Normally, these muscles pull their sternoclavicular origin and bring an upper arm to the body in a hugging motion. When functioning as accessory muscles of inspiration, they pull from the humeral insertion and elevate the chest, resulting in increased anterior posterior diameter. Patients with COPD frequently brace their arms against something stationary and use the pectoralis muscles to increase the diameter of their chest. It's also called tripoding. So this is how COPD patients tripod, how they use the pectoralis muscles for inspiration. They lean forward, they put their arms on it, rest their arms on a chair or on a wall or on a bedside table, and use the pectoralis muscles to make it easier for them to breathe, to get a bigger breath. So let's talk about the action of the trapezius muscles. The trapezius muscles are large triangular muscles that are situated superficially in the upper back and the back of the neck. They originate from the occipital bone, the ligamentum nuchae, and the spinous process of the seventh cervical vertebrae and all the thoracic vertebrae. They insert into the spine of the scapula and the acromion process and the lateral third clavicle. Normally, the trapezius muscles rotate the scapula, raise the shoulders, and abduct and flex the arms. Their action is typified by the shrugging of the shoulders. When used as an accessory muscle of inspiration, the trapezius muscles help to elevate the entire thoracic cage. So accessory muscles of expiration include the rectus abdominis muscles, the external abdominis oblique, the internal abdominis oblique, the transversus abdominis muscles, and the intercostal muscles that are all pictured here. One last accessory muscle of expiration that I want to talk about is the intercostal muscles that run between the ribs immediately beneath the external and internal muscles. The muscles arise from the inferior border of each rib and insert into the superior border of the rib below. The internal intercostal muscles contract during expiration and pull the ribs downward and inward, decreasing both the lateral and anterior-posterior diameter of the thorax. This action decreases lung volume and offsets the intercostal bulging during excessive expiration. As you can see in the picture, this is the collective action of accessory muscles of expiration causing inner pleural pressure to increase, the chest to move outward, and the bronchial gas flow to increase. So I have a question to test your knowledge. Which of the following are accessory muscles of expiration? Rectus abdominis, transverse abdominis, internal intercostals, or pectoralis major? Can you remember? We just talked about it. It's rectus abdominis, transverse abdominis, and internal intercostals. The pectoralis major are accessory muscles for inspiration. One more question. What happens to the airways during inhalation and exhalation? When do they dilate and when do they constrict? They dilate on inhalation, and on exhalation, they constrict. That ends our PowerPoint for today. I want to thank you for watching and for working so hard.